good. Hello everyone, my name is Man. I'm a pharmacy resident at Providence St. Mary Medical Center, and today I'm going to present about my project implementation of a pharmacist-led positive culture protocol for discharge emergency department patients. And I have nothing to disclose, no conflict of interest, no sponsorship. And at the end of this presentation, these are my learning objectives: recognize the pharmacist's role in evaluating cultures, draw on patient discharge from the emergency department, identify an opportunity for improvement in prescribing antibiotic practice, and identify optimal treatment for skin soft tissue infection and urinary tract infection for discharged patient from the ED. A little bit about Providence St. Mary Medical Center. So we are a rural hospital in Walla Walla with 142 beds. For my project, I focus on the emergency department, and in the ED there are 24 beds, 2 to 3 providers per shift, and we have one charge nurse as a unit coordinator responsible for the culture log during daytime, and we only have 80 pharmacists coverage during graveyard shift. So now we're going to the pre-test assessment question, and the answer we'll discuss about the answer at the end of this presentation. Which of following therapy can be used to treat a complicated UTI with systemic symptoms? Which of the following antibiotics are not indicated for SSTI? And the last question, what are signs and symptoms of UTI? Now let's go into the background. Emergency department practice for the current culture review process. They review the culture every 24 hours by the RN unit coordinator. The emergency department provider have frequent interruption while managing patients in the emergency department, which could impact the culture review time. And for the role of the pharmacist in the antimicrobial stewardship has expanded. The Joint Commission allowed the qualified pharmacists to lead antimicrobial stewardship program due to their substantial knowledge of infectious disease and antibiotic and antibiotic therapy. Studies have demonstrated that the benefit of pharmacist ED culture review, including reduction in time to optimal therapy and readmission rates. Now let's go to the methodology. For a study objective, we evaluate the impact of the implementing of pharmacist-led culture for patient discharge from the ED, focusing on urinary tract infection and soft tissue, skin soft tissue infection. For the primary outcomes, we'll focus on the time from positive culture result to the time of the new antibiotic therapy prescribed. For the secondary outcome, we want to focus on the average duration of therapy, how many days different, and we would like to track the resistant culture pattern of organism isolated. For the criteria, inclusion will focus on patients over 18 years old, positive culture result for discharge ED patient, and then antibiotic therapy for UTI and SSTI. For the exclusion, we'll exclude patient under 18 years old, pregnancy, hospitalized patient, immunocompromised, patient with sexual transmitted infection. And let's go to the enrollment and the study design. So we'll use the get the data from that data from last year. That's the culture led by the nursing from January 1st until February 5th, and then we'll compare with the culture this year led by the pharmacist with the same time frame, and we'll focus on the urine and the skin culture. For the pharmacist workflow, pharmacists will come in, review the culture log daily, and focus on skin and urine culture, and then pharmacists will provide an antibiotic recommendation to the ED provider. After that, when the ED provider responds and accept the recommendation, the pharmacist will send out a prescription for the ED provider, and the pharmacist will call and counsel the patient, or message on the patient portal, and then the documentation of the antibiotic change will be documented by the pharmacist. And here's the results. For the primary outcome, so we can see the two different led by between the pharmacist and nursing led review, especially in the urine culture. So out of this total 61 culture during that time frame, we have 8 total intervention, which represent that the ED provider did a great job on using the empiric therapy. And when for urine culture for UTI, we see that restriction change would perform less than 12 hours, and we complete faster led by the pharmacist group. So for the pharmacist culture review, it took them like 15 to 20 minutes to review the culture and send out recommendation. It took provider 1 to 2 hours to respond back and accept the recommendation. Just when they have like one culture like Escherichia vulgaris, it took like 48 hours to request for literature to identify the appropriate therapy. And for total time of culture review is varied because due to like waiting for a provider responding, calling patient, counseling patient, and then literature review. And for a secondary outcome, so as I mentioned, we try to track the resistant pattern of the organism isolated, and we just try to determine that if those organisms or bacteria will affect our primary outcome, to see if any different coming out of it between the two groups, pharmacist group and the nursing group. And so we can see in the nursing group, we have like the E. coli, 38%, Pseudomonas, 19%, and then the Proteus is 13%. And in the pharmacist-led group, and we have like 20% of Enterococcus faecalis, 13% E. coli, 20% Pseudomonas, and then 13% of Citrobacter. And secondary outcome, we try to track the duration of therapy to see if it's any different, led by the pharmacist and the nurse. And we can see the difference here that the duration reduced by 2.75 days in the pharmacist-led group. For the conclusion, so we see that pharmacist-led group have a faster prescription time, even though we have like more ESBL, Pseudomonas, and then Citrobacter pylori organism, like compared to that more than like in our, that's compared between our group and to a nursing group, but we still have faster time, right? And then the provider and the nurses and patient appreciate the calling and counseling from the pharmacist and for the treatment of SSTI and UTI. For the discussion of this study, for the strain, we have faster time for the neuroprescription, and then we have a AMS expansion in the discharge ED patient with the shorter duration of therapy, and would educate the ED provider for any change of the antibiotic, and then we recommend to the provider, and it was accepted 100%. The limitation, we have a small population size, shorter duration, shorter project time, and with a small number of intervention, because we didn't have the lack of collaborative drug therapy agreement, so our recommendation had to be weighted and approved by the provider before we make any change. So for future direction, we would like to expand our pharmacist responsibility to the blood, respiratory culture, pediatric patient, sexual transmitted management, and then we'd like to recruit ED pharmacists during daytime to allow for pharmacy management of the ED culture, and then we'd like to develop a protocol under CDTA to change the therapy independent, and we'll implement some AMS education to the ED provider about common infection. Now, let's go into the answer for the pre-test assessment. Which of the following therapy can be used to treat a complicated UTI with systemic symptom? A. Fosmicin, nitrofurantoin, Bactrim, and ciprofloxacin. The answer is C and D. Second question, which of the following antibiotics are not indicated for SSTI? The answer is E, Vanco Oral. And what are signs and symptoms of UTI? Select offline. And the answer is fever, flank pain, and then dysuria. That's all my references. And the floor is open for any questions.